All requesting all to keep your videos if possible. Thank you all for joining us today. Today we are going to discuss on management of pain part 1. We have our faculty Dr. Sreedevi joined us here. From the previous session, all of you are familiar with her. I think there is no need of further faculty introduction for her. For further session facilitation, I invite Sister Anu. He's our facilitator. She has joined us. Thank you, Anu, for joining us. And over to you.
Do we want to wait for others to join? I think only 26 and 24 have joined.
We can just wait for 2 minutes, ma'am, or we can start.
We can start off. We generally maybe 1 minute or so. Generally start at one time.
Okay, let us start. Good evening, everybody. Hope your course is going on very well. Today's session is Introduction to Management of Pain, Part 1. As Srini told, there is no, we are very familiar with the Dr. Sreedevi right currently. So I'll be sharing an overview of today's topic. So today we will be discussing about WHO analgesic ladder, principles of WHO analgesic ladder, and the drugs in step 1, 2, except opioids. And we'll be describing the drugs used to treat neuropathic pain, and the main part is nurses' role in pain management. I welcome Dr. Sreedevi ma'am to take the session.
Thank you, Anu, for introducing the topic to the team. Good afternoon, everyone. Hope you are enjoying the sessions and learning from each session. If there is any difficulty, please do write to us so that we'll try to improve sessions if there is anything which you find difficult to learn. So as Anu mentioned, we'll be touching upon the WHO analgesic ladder. I think Dr. Farhana mentioned it briefly during the last session probably, but we'll look into it in detail. And we'll go through. I'll be focusing mostly on step 1 and adjuvants because it's easier to talk about step 2 because in the along with the strong opioids or step 3. So we'll see how it goes and then we'll proceed accordingly. So start with the first part. Sorry for that technical error. So this is everyone familiar of the WHO analgesic ladder? Has anyone of you have learned it? I understand some of you are already working in palliative care. How many of you are familiar with this ladder, have heard it before? Can you just raise your hands and or unmute? Anyone has heard or not heard? Any response? Yes, I understand Mamta has heard about or learned about WHO ladder, I guess. Okay. There are no other hands coming up. Either you are not there or you have not learned about the WHO ladder. Yes, Aarti has not heard about it. Even till the time I came to palliative care, actually, I hadn't heard about the WHO analgesic ladder, although we deal or see a lot of pain while we are seeing patients in the college days, but this was something very, very new, which I heard for the first time when I went to palliative care department while doing the internship. So this is that ladder. I know it's slightly difficult to read from the steps, but we'll be sharing the presentation and you get this ladder everywhere in the internet. So this ladder is not very new invention. It is invented in 1980. So it's a very long time that people are talking about this, but we have not learned about it. So there are 3 steps in WHO analgesic ladder. So this started basically for cancer pain management. But nowadays we use or refer this ladder for many chronic pain situations also. But when it was started, the WHO ladder started mainly for cancer pain control. So it's named as, it is mentioned in the WHO cancer pain guidelines. So there are 3 steps. Okay. Just need to remember step 1, 2, and 3. Step 1 has, they recommend the use of non-opioid drugs. We've learned in our pharmacology sessions, if you remember, NSAIDs and everything comes under non-opioids. So in the step 1, they recommend to use non-opioids. In the step 2, that means a little bit more pain. So this use of ladder is related to the severity of pain. I'm sure in the last session, Dr. Farhana might have mentioned about the pain assessment, where we ask about the severity of pain in a scale of 0 to 10, or we ask whether it is mild, moderate, severe. So according to the pain, we choose which step of the ladder that we can use. So if the patient is telling mild pain, we'll start with step 1. Step 1 has basically non-opioid drugs, any analgesic which are not opioids, non-opioids. Step 2 has weak opioids. Okay. And step 3 has strong opioids. So non-opioids, weak opioids, and strong opioids. Very simple to remember. And in all the steps, I have mentioned something called adjuvants. We'll come to that later. So along with step 1, 2, 3, along with the drugs mentioned in 1, 2, 3, in every step, we will give something called adjuvant analgesics, which we will learn today again. Another speciality of this step is that step 1, which is non-opioids, can be given in step 2 also and step 3 also. Okay. So there are certain principles when we use these drugs. So I'll just go through it once again so that you remember everything. Step 1 has non-opioids plus or minus adjuvant analgesics. Step 2 has weak opioid. Nowadays, we don't say weak opioid, we say opioids for mild to moderate pain. Weak opioids plus step 1, plus or minus step 1, plus or minus adjuvant. So you can give adjuvants in all the steps. You can give step 1 in all the steps. Is that clear? Okay. So we'll go to the general principles of using, how to use the drugs in this ladder. So there are certain principles WHO recommends when we prescribe drugs. The first principle, especially for cancer pain, it has to be by the mouth, by mouth. Whichever medications you choose, it is always better to give it orally. Otherwise, I can see a comment. Sister Winnie is telling to go through it once again. It has to be very clear. So I'll just go through it once again. So there are 3 steps. We choose which step drugs to be given according to the intensity of pain. If the pain is mild to moderate, we start with the step 1. Step 1, what does it contain? It has non-opioids plus or minus adjuvant analysis. So you can give non-opioid drugs. If you need, you can add on a adjuvant analgesic drug to step 1. This is very important. Even if you are nurse, even if you are not prescribing, you have to understand the 3 steps of it. And if the patient is telling, I have moderate pain, somewhere between moderate to severe, it is not yet severe, but moderate pain. Pain scale, he may be 5, 6, 7, 4, 5, 6, 7. Patient is telling moderate pain, you have to start with the step 2. Step 2 has weak opioids. I'll tell you full few examples. Weak opioids means tramadol. Tramadol is a weak opioid, or codeine is a weak opioid. So all these drugs come into step 2. Step 3 has strong opioids like morphine, fentanyl, methadone, etc. And one specialty is that adjuvant analgesics can be given in all the 3 steps. Step 1 can be given in step 2 and 3 also. You will understand it better when you hear about the drugs, how you can combine all this and what are the things to be kept in mind. If there is still doubt, please let me know. So whenever you give analgesics, you have to give it by mouth because you're treating pain. It is not like you have a toothache and treating for one day where you can just give an injection, or it's not like a muscle pain for one day where you can give an injection diclofenac and send the patient back. No, these patients will have pain for a longer period of time, right? They can't come to hospital to take injections 3 times or 4 times a day for a period of 2 to 3 weeks. So any medication that we give, the first principle is to start by mouth. Second thing, generally we see a trend that we give the medications SOS. When you have pain, take this tablet. That is not the case. In pain management, you have to give the medications by the clock. So you have to understand a little bit about the pharmacology, like how long this medication is going to act. For example, if your medication is going to act for 6 hours, you have to give it every 6 hours. We have learned this in pharmacology, but when we give to patients, what we say, you take it when you have pain, right? But what happens in cancer pain or chronic pain? The stimulus is still there, right? The lesion is still there. The nerve, whatever nociceptive pain, that stimulus is still there all the time. You can't just give SOS. You have to give it by the clock. Whichever medication you are giving, understand how long it is going to act, and accordingly, you have to give it 24 hours round the clock. The third principle is by the ladder. That means when, as I told, you relate the pain severity. If it is severe pain, start from, so this step, WHO ladder, you don't need to climb every step. If the patient is having severe pain, you don't need to wait from step 1, step 2, and step 3. It is not like that. If the patient is telling you severe pain, start right from the step 3. Is that clear? It is according to the intensity or severity of pain. You don't need to climb all the steps to reach there. You can climb from the top also, depending on the pain severity. So, follow the ladder is the third principle. The fourth principle is very, very essential for nurses to understand, that is attention to detail. So, you give a drug, you have to ask more about it. When the patient takes the drug, if he's in the IP or if he's in the home care or OP, you have to ask for every attention, side effects. There are many side effects for medications that we give. So you have to ask specifically how much your pain comes down from 10 out of 10 after taking this tablet, how low it became. Has it come down to 5? If it has come down to 5, like after taking the medicines, how long you have the pain, reduced pain, how long you have relief. So every details you have to ask very specifically. That is the key to good pain management. We will just move on to step 1 today. If this is very clear, you have to understand it has to be given by the mouth, by the clock, by the ladder, and attention to details. These are the 4 principles. And when we come to step 1, generally step 1 is used alone, or you can, as I mentioned, you can combine adjuvant analgesics if it is mild pain. Sometimes the drugs in the step 1 is given along with weak opioids and strong opioids. Sometimes we need a combination of step 1 in all the steps. So step 1 can be given in all the steps. Very simply. Adjuvants can be given in all the steps. Step 1 can be given in all the 3 steps. Okay. So this is one question. You have learned about the pain assessment, right? So this is a 40-year-old male with carcinoma lung. He told you that there is a deep gnawing pain over the right supraclavicular and infraclavicular areas, here and below the clavicle and above the clavicle. And when you asked, he told the pain score is 3/10 during the daytime. But at night, I have pain which goes up to 4/10. If this is a patient coming to you, how will you assess this patient? I'll wait for some chats or some response from your side. What else you will ask for? You want to know something else before we choose the medication? I'll look for the chat. I'm not going into the details, the next case, because we may not have time for 2 case discussions. So I'll take up the questions as and when it comes in the chat. Yes. Sister has mentioned about step 3. Here we have to understand, Sister Alvin, that the pain is three or 4.
Excuse me, ma'am.
Yes.
Excuse me, ma'am. Somebody is mentioning it's not hearing. I'm not so sure. I can hear it very clearly.
Sorry, sister, she hasn't connected. This is the
Her
day of
audio is not connected.
Yes.
That's I think they are sending messages. Can you send?
I'm looking into it.
So, Sister Alvin, you have mentioned about step 3. Here the pain score is 3 out of 10 all the time in the daytime, right? So that comes into the margin of mild pain. 1, 2, 3 comes under mild pain. So when someone has mild pain, you can always give step 1. If it is like 4, 5, 6, or probably 4, 5, 6, it is a moderate pain. Then you can give step 2. Step 3 can be given when the patient is telling he's having severe pain, that is 7, 8, 9, 10, you can give step 3. Yes, Sister Winnie, yes, we can start this patient on step 1 analysis. So I understand that is a little clear. So yes, I can't just say that I will start with step 1. I have 100 questions to ask this patient. What kind of pain, where it starts, what is the radiation, when it started, why it is 4 at night. That is very important question. Patient will tell you that when I sleep, I'm very scared. Everyone is sleeping. What if I die? No one comes to know. So when everyone is sleeping, I'm very scared. So my pain score increases. So there are thousands of questions that you can ask with this kind of, it's not, I can't just say, okay, pain score is 3 out of 10. So I'm starting with step 1. No, it's not like that. But for today's session, because we are learning the WHO ladder 1, step 1, that is why I told we can choose drug from the step 1 ladder. So why do we use NSAIDs? It is used to manage mild pain. Generally, we don't give it for moderate pain. It is the first step. You can give adjuvants. You can or you may not need adjuvants depending on the type of pain. And generally, step 1 is useful in inflammatory pain and bone pain. So what are the drugs? So this is what are the drugs used in step 1? We said it is non-opioids. Can someone tell me few non-opioids example? One is right there in the screen, which is paracetamol, which is one very, very important drug that we use in palliative care. Most of the prescriptions will have paracetamol. Diclofenac, yes, that is one drug in step 1. Non-opioids. We have learned it in pharmacology. Aceclofenac, yes.
Tramadol.
Yes, tramadol, sister, it comes in step 2. It is more like, it is a weak opioid. Tramadol is, although we give tramadol right and left, it is not a non-opioid. It is a weak opioid. But we don't think that it is an opioid. When it comes to morphine, everyone is scared to give. Tramadol is also an opioid. Brufen, yes. Combiflam, yes. Yes. So now we know what are we going to learn about. So paracetamol is an important drug that we use in step 1, but paracetamol does not have any anti-inflammatory activity. Okay, so it is not an NSAID, but it comes in step 1. It is not a non-steroidal anti-inflammatory drug. The other drugs that you mentioned, diclofenac, aceclofenac, brufen, combiflam is a combination drug. So everything is a non-steroidal anti-inflammatory. You might have learned in pharmacology NSAIDs, COX-1, COX-2, many things we have learned, right? So these drugs comes under NSAIDs. So how do we use paracetamol? Generally, what we give 500 milligram XOS, sometimes 250 milligram, right? Sometimes 500 milligram BD. Generally, we use it for fever in your routine settings, but in palliative care, we use it as an analgesic. This is the dose of paracetamol that you have to prescribe. That is 12 milligram per kilogram body weight every 6th hourly. It is not BD, TID or anything. It has to be given every 6th hourly. Sometimes we do give, if it is severe pain responding to paracetamol really well. Sometimes we go a little above it, but that is very, very rare. You just have to remember 12 milligram per kilogram body weight, 6th hourly. So how much will you need according to your body weight? Most of us need more than 500 milligram, right? Most of us need more than 500 milligram. So now in our country, we have the 650 preparation, which is ideal. But sometimes we give 750 milligram 6th hourly according to the patient's body weight. Sometimes patients need 1 gram 6th hourly. Okay, so the maximum dose of paracetamol is, we can go up to 4 gram. 4 gram per day. That is the maximum dose that you can give. Is there any side effects for paracetamol? The moment you tell patients to take paracetamol, they are very scared. Oh my God, my kidney is going to be damaged if I take 4 paracetamol in a day, right? Paracetamol doesn't have any effect on kidneys. It can have effect on liver. It can have, yes, very correct, Divakar. Hepatotoxicity is one thing that we have to keep in mind. But hepatotoxicity happens in a very high dose. So when my patients ask me, I ask, do you plan to take 10 paracetamol together instead of 1 at a time? Then they say no. Then you don't have to worry about the liver toxicity. Unless you have a patient with liver failure, you have to be a little cautious about giving the 4 gram dose, but we still give 500 milligram dose. 2 gram can be given very, very safe. So when patient asks about paracetamol and kidneys, no relation. Paracetamol has effect on liver, but unless you take a very high dose, you are not going to end up in any toxicity. We go to NSAIDs. I'm not going into the pharmacology class today, but this is very informative and interesting. So I'll make it as simple as possible. There are 2 things that we have to remember. I don't know whether you remember what Farhana mentioned about the prostaglandins. When you have a needle prick, when it is next day, you can see reddish patch over the needle prick, right? When you have a cut with the knife, the first day the wound look very clean. The next day you can see slight redness around and you feel little pain around the wound, right? On your finger. So that is where the prostaglandins are being released. That is why we have that pain around the wound the next day. So NSAIDs basically inhibit the prostaglandins. It just stop the production of prostaglandins. Prostaglandins are the substance which cause the inflammation and in turn pain. So NSAIDs inhibit prostaglandins. You don't need to remember all these things, but I feel it is very, very important for nurses to understand a little bit more. Because you are the people who just give the medication. You should know what you are giving, right? That's very interesting to learn also. So if you are interested to learn, you can learn. Otherwise, just know about the side effects and when to give. So there are 2 mechanisms, COX-1 and COX-2. These are the mechanisms by which prostaglandins are produced in the body. COX-1 means it is there everywhere. It is constitutive. Every tissue, your GI tract, your tissues, your some of the nerve endings, everywhere you have COX-1. You don't need to read the slide. I'm not reading anything from the slide. COX-2 happens only at the sites of inflammation. Only when you have inflammation, COX-2 is like a defense mechanism, right? Only when you have an injury, the COX-2 is being released. So when you give your drug, the brufen, diclofenac, some of the drugs acts on both COX-1 and COX-2. Some of the drugs acts only at COX-2. So now, when we talk about the drug, you know which drug is what. It's very important to understand that. So COX-1 and COX-2. COX-1 is present everywhere, kidneys, gastric mucosa, but COX-2 is produced only when there is an inflammation. Sorry. So what are the adverse effects? Now we heard that COX-1 is present everywhere, right? Gastric mucosa, kidneys, and in blood cells, platelets. So when you give this drug, it can affect everything. It can cause gastric irritation, it can cause renal toxicity, and it can cause diminished platelet adhesion. That means platelet will not clot. So clot will not form. So when there are tendencies to bleed. If already has a bleeding, it will bleed more. Any clue about the drugs, COX? Now you mentioned diclofenac, brufen, combiflam. Which class of drugs they are? COX-1 or COX-2 or both? Any idea? It can be wrong, no problem. There is no one judging you here. I learned after reading so long. Both. So, whichever drugs you mentioned here, brufen, diclofenac, and aceclofenac, everything is like they inhibit both COX-1 and COX-2. Any example that you heard about COX-2 drugs, which acts only, so you can see it can be advantageous, right? When you give COX-2 drugs, preferential selective COX-2 drugs, it acts only at the site of inflammation. It will not go everywhere. That means lesser side effect profile. Any examples of COX-2? Orthopedicians use that drug a lot. If you have worked in the ortho OPD or ortho department, they are very fond of this COX-2 drugs. Any COX-IBs? Etorecoxib, right? Etoshine is one of the very commonly used drugs by the ortho people. So, etorecoxib is one of the COX-2 inhibitor that is very widely used in our place. So, what are the adverse effects? Gastric irritation. So, these are the things that you need to know. When the doctors prescribe NSAIDs, you have to ask the patient about the gastric irritation, about the urine output, whether they are drinking enough water, because in palliative care, most of the patients are very fragile, very weak, right? They can't drink a lot of water. They might be already dehydrated. So you have to ask whether they have any issues in the tummy, burning sensation, any issues with the urine output, any burning micturition, or are they not drinking enough, and whether there is any bleeding tendencies. If they already have a cancer which is bleeding, a breast cancer which has bleeding, the doctor will give NSAID, it will bleed more. So you are the people who will know more about it. So you have to ask all these questions. The problem with the gastric irritations is that patient may not, some patients, they feel, you might have heard, no, the moment they take Brufen, they say gastric irritation, oh, burning tummy, my tummy is burning. Some patients, it may not happen, but it can actually cause ulcers or erosion. So it's very, very important to give a proton pump inhibitor, that is pantoprazole or omeprazole, every time you give an analgesic. So I still remember during my initial days, when I prescribed ibuprofen, one nurse came and asked me, are you not giving omeprazole because you are giving an NSAID? So that's how nurses have to remind or remember all these points, that you can be with the team. If someone is not prescribing a PPI, you cannot just, okay, doctor prescribed it, so it is the best thing. No, you have to ask whether you need to give an omeprazole or pantoprazole. Otherwise, patients will end up in trouble. They'll have gastric perforations. Second thing is renal. So these are the symptoms that patient will tell you. They may say nausea, vomiting, bloating. These are the very common thing that you might be hearing. My tummy feels full when I take this medication. There can be dyspepsia, regurgitation, bleeding. So it is very, very important to give a proton pump inhibitor and ask for these details. And you can't give it for a longer period of time. Renal toxicity, generally it happens with dehydration. When you're drinking enough water, there is no chance for renal toxicity. Or if there is any existing renal issue, if there is an existing hypertension, it can cause worsening. Many of our patients will have all these issues. So we encourage them to drink fluids, or if they are too dehydrated, we don't give NSAIDs. The third, then I asked about etoricoxib. I understand that many of you don't see etoricoxib very commonly, but doctors' favorite drug is etoricoxib. They think that it is the safest because it acts only on COX-2. So they think that it doesn't have any side effect. But yes, you have to remember, even if it is COX-2 drugs, it can cause problems with the kidneys. It is not renal friendly. It can cause problems with the kidney. It is not, but it will not cause gastric irritation, but it can affect kidneys. Sorry. So what happens with the COX? I'm not confusing you. You just don't need to understand about each and everything. Sorry. So this is one thing that you need to understand, that many of your patients will be on ibuprofen and many of them will be on aspirin for their heart issue, right? So when they are prescribed together, the doctor might have given both aspirin and ibuprofen. It should have at least 30 minutes gap. Okay? Take ibuprofen first. After 30 minutes, you give aspirin. So these are the things that you need to understand. Even if you don't remember or forget completely about COX-1, COX-2, that's fine. But you have to remember this simple attention to details. And when you give this together, already it is gastric mucosal damage it is causing. When you give two drugs together, high chances of gastric mucosal damage. So you have to make sure that the patient is taking PPI half an hour before. So you give either omeprazole or pantoprazole before taking any NSAID. Sorry, these are all not important. So we'll just come to the current recommendations. We should start with 4 gram up to 4,000 milligram per day of paracetamol. Acetaminophen is paracetamol. So you can go up to 4 gram. That means you can give up to 1 gram every 6 hours. You can give up to 4 gram. Then you can try oral NSAIDs. Paracetamol is very, very, very effective in pain management. It's a wonderful drug if you give it round the clock and the correct dose. And if the patient is very elderly, it is better to give topical. But one thing I learned in palliative care, we don't think about the topical. We just give a diclofenac gel. They use it everywhere. They finish the whole tube in 1 or 2 days, right? Because it is topical, people think that it is very safe. No, it is. Why is it acting? Because it is getting absorbed into the bloodstream. So whatever toxicity we are telling, it is applicable to any topical analgesic, which I didn't know. I thought it's okay when anyway it is topical and the patients will finish the tube in 1 or 2 days because they apply it everywhere. So you have to tell them, even though it is topical application, it has its own side effects. It gets absorbed into the systemic circulation. I learned it when people from other countries came here and they were so shocked to see the amount of topical that we use. So they told, no, it has to be very, very limited. It is like any other analysis. And it is very effective in elderly patients. So coxibs means etoricoxib or rofecoxib, celecoxib. Others are not available. Etoricoxib is the only one which is usually prescribed. It should not be given in patients with stroke or heart disease because this drug, etoricoxib or diclofenac even, can cause platelet adhesion. It can cause thrombosis. So in a patient with heart problem, it is better to avoid diclofenac and etoricoxib for a longer period. 1 or 2 doses, that's fine. If you are planning to give for more than 2 to 3 weeks, it is better to avoid etoricoxib and diclofenac because it can cause thrombus, it can cause clot, which can cause heart problem or stroke. But the problem with the other drugs, ibuprofen, etc., is that it can cause gastric irritation. So you have to, that is why attention to detail is very, very important. If the patient cannot tolerate ibuprofen because of severe gastritis and she already has a bleeding tendency, it is better to give COX-2. But if there is no contraindication, it is always good to give the normal ibuprofen. So ibuprofen is a commonly used drug in our setting. we give 400 milligram up to 8th hour. 8th hourly is the dose. But we always give a proton pump inhibition. But you keep in mind that NSAIDs, you have to give the lowest dose possible for the shortest period of time. You cannot give it for months or years because it has a lot of problems in the tummy. It can cause bleeding. It can cause cardiac issues. And sometimes in our patients, we use a lot of NSAIDs, even though it has all these issues, because they respond very well, especially the bone pains respond really well. So even though this has side effects, I'm not telling not to use it. Many a times we have to use these drugs to control pain, but we have to understand and ask whether they are okay, whether they are tolerating, whether it is going to be helpful. I'll just quickly go to the next presentation on adjuvants. Today we are covering a little bit on adjuvants also. Adjuvant analgesics. Any idea about what it means by adjuvant analgesics? Anyone? And if you have any doubts in step 1, please type it in the chat. I'll take it towards the end. Anyone? What do you mean by adjuvant analgesics? Yes, Mr. Mehabu. You are muted. We can't hear you.
Yes, now you can hear me?
Yes, please.
Yeah, like along with the pain reduction drugs which we are using, along with that we are giving some prednisolone, cortisone, which helps in reduction of pain, the inflammation.
Thereby reducing pain, right?
Yeah.
Yes, that is one explanation for adjuvant, and it's very rightly said. Anyone else? Yes, that is also true. It enhances the action of the given drug. Anything else? So, very true. Both of you said the correct answer. Yeah, the third response is also correct, which we add to enhance the pain relief. But this drugs, the primary indication will not be pain. Like you mentioned about the prednisolone. Prednisolone is not an analgesic. The primary indication for these drugs will not be pain, but it has an analgesic action at some doses, or you give it for reducing pain. As you said, the right example is a steroid. Steroid is not an analgesic. It is an anti-inflammatory drug. But you give steroid so that the inflammation is reduced and the pain is reduced. Like that, there are many drugs. The primary indication, yes, correct, Aarti, the drug which has analgesic property, but the primary purpose is not analgesia. The primary purpose will be something else. But we modify the dose and giving it for analgesia. This has to be very clear. I've heard people telling blunters when we ask adjuvant, they say it is antiemetic. It is a drug given for constipation. No. These are drugs which are not primarily painkillers, but we use it in a different dose for analgesic action. Okay? I hope that is very clear. Where is it being used? We just mentioned what in all the steps. Step 1, 2, and 3, in all the steps, we can use adjuvant analysis, depending on the pain. Sometimes you may not need it, but when you assess pain, you are asking about the type of pain, radiation, right? You ask so many things. And if you think that, okay, I need this particular drug so that this kind of pain is reduced. So after good pain assessment, if needed, you can use adjuvant analgesics in all the 3 steps. Okay? This is another ladder. So I'm introducing 2 ladders. You don't need to by heart it. I still don't remember the steps in this ladder because it's a little complicated. But this is a ladder for treating neuropathic pain. I'm not going into details. We'll come to that one by one. So how we are focusing now more on neuropathic pain. Last class, you heard about the nociceptive and the neuropathic pain, right? So what happens in neuropathic pain whenever there is nerve compression? You have a tumor mass which is compressing the nerve, or you have a fracture in the vertebra and the fractured segment is compressing a nerve. So any nerve compression can cause neuropathic pain. Or if there is any direct nerve injury, you have a cut, you have a lesion, and the nerve is completely damaged, that is another reason. It can be due to stroke. That means stroke happened, so it has affected the brain itself. So some of the areas will have neuropathic pain. Or it can be due to plexopathies, like we see in diabetes, or we see in some chemotherapy drugs, they say peripheral neuropathy. So these kind of plexopathies, these are another reason for neuropathic pain. So where do you see this kind of neuropathic pain? Anyone? Commonly seen situations. We just mentioned a little. I'll just give us start. Where all we see this kind of pain? Do we see that in cancer? Neuropathic pain, any chance to see that in cancer patients? Yes, we see that a lot in cancer, but it is not just in cancer. Many other illness you see. Just now I said an example, diabetes. People say there is numbness. I feel like I'm walking on pebbles, or I am walking on, yes, tumor compressing the nerves. Sometimes patients will tell you that I can't feel anything under my feet. My feet is burning. Right? So there are so many illnesses. Have you heard about phantom limb pain? When someone has severe pain before amputation, they undergo amputation. After the amputation, the leg is not there anymore. The limb is removed, but they will feel the pain in the removed limb. And people call them mad. Have you heard about this phantom limb pain anywhere? It's not that uncommon. So when they have uncontrolled pain before surgery, your brain is used to get signals about pain, right? They must be in pain for many months or weeks. And then once the surgery is over, that leg is removed. That leg is not there in your body, but they will still feel the pain on that leg. A lot of therapies involved in treating the phantom limb pain, and the relatives will be so frustrated. They will tell you that, oh, this person is telling that he has pain. He doesn't even have the leg. Yes, Mehboob, you have any question? You are muted, ma'am. I think.
Hello.
Yes, ma'am.
Yeah, one of my friend's brother was operated. He had diabetic foot and he has undergone the amputation. And in the middle of the night, he used to get up and cry so much that he used to feel that the rush of blood circulation is going till the foot end, but the foot end is not there.
Yeah, exactly. That is the exact presentation. And sometimes the doctor will tease them.
Yeah.
They are labeled as, they are generally referred to the psychiatry department just to, yes, there are a lot of therapies which is to be done. One thing, if you search in the internet, you will see mirror therapy. They'll keep the mirror in front of the patient and tell them to imagine and look at the foot to make sure that the brain should register that the foot is not there anymore.
Yeah.
So there are a lot of therapies, but they actually feel the pain. It is a terrible situation where you don't have the limb, but you feel the pain.
Yes.
Thank you for sharing that.
Thank you, ma'am.
Sciatica is another example where people say back pain, leg pain. We see that very commonly. Cancer and its treatment, diabetes, which we already mentioned, trigeminal neuralgia, where any chewing or any touch on the face can cause pain over the trigeminal nerve distribution, usually with the mandibular nerve. HIV, many of you might be seeing a lot of patients with HIV, right? Some of you might be in the rural areas. So HIV has a lot of neuropathic pain syndromes, a lot, many of them, peripheral neuropathy, flexopathies, a lot of syndromes associated with HIV. Herpes zoster, I don't know whether you have seen herpes zoster. It is another terrible way of having neuropathic pain. Once you have the chicken pox, the virus will remain in your nerves and it precipitates after so long. So wherever the nerve distribution, they will have vesicles and severe neuropathic pain. That is another syndrome which can cause neuropathic pain, complex regional pain syndrome, and many a times patients with stroke will have neuropathic pain. Why do we need to learn about adjuvants? Because even in cancer patients, almost 84% of patients were on adjuvants. Most of the patients will need adjuvants along with their step 1, 2, and 3, because usually the pain will be a combination of nociceptive and neuropathic and bone pain, or it can be due to the chemotherapeutic drugs. It's a combination of many pains. So you will need an adjuvant analgesic in almost all the steps. Most of the patients will need adjuvants. And how will the patient present to you? You might have learned this in pain assessment. If the patient has a neuropathic pain, what will they tell? What terms they use? I'll start with an example, burning. Tingling, yes, very commonly said. Tingling pain, tingling sensation. Burning. Has anyone heard about people telling you ants crawling over my legs? Ants or insects crawling everywhere. So you have to look for these cues. Numbness, yes. Heaviness sometimes. Needle-like sensation, burning, yes, very good, very, very good. Thank you everyone for the response. These are the very commonly said. This is exactly I have on my slide also. You've said everything. They say burning, numbness, they say lancinating pain, shooting pain, raw skin feeling. They sometimes see that I have that my skin is very raw. There is a lot of wound. And many times they say, I have a feeling like ants and cockroaches crawling everywhere. So these are the commonly said features of neuropathic pain. I'm not going into details, just to remind you that this is the pathway when you have an injury that is conducted to the dorsal root ganglion, there to the brain. From brain, the signals are coming down to the descending pathway and conveying the signal to you how to react to it. I'm not going into details. I'm sure you might have seen this in the last session. So these are a few things that you have to remember. Pain receptors do not adapt. We say that after some time you will get used to the pain. You will not get used to the pain. The pain receptors will not adapt according to the stimulus. It will continue to sense pain. As long as the stimulus, you imagine you have a needle prick. You have pain, right? But does it mean that if you have needle prick 24 hours, you keep your finger under a sewing machine and switch it on? Do you think your pain will reduce after some time, or you will keep sensing the pain? You keep sensing the pain. Your pain receptors will not adapt. As long as the stimulus is there, you will feel pain. And there is sensitization of nociceptors, and the pain area will increase. I'm sure this was mentioned in the last class. If you don't treat the pain, the area will increase. It will start with a small back pain. Later on, it will become the whole back, and then it starts radiating to the whole body. And the patient will tell you, I have head to toe pain. So if you don't treat the pain in the beginning, there will be worsening in the intensity, severity, and extent. I quickly went through this because I'm sure you might have heard it already, but I don't want to go into the details, but just remember all these points. You have to treat pain very, very early. And we always tend to compare patients. Patients will have same injury, but different pain. We'll say, oh, that patient is also having diabetes. He doesn't have this kind of pain. You cannot tell like that. Same injury can cause different pains. Same pain can be due to different injuries. Sometimes 2-3 patients will tell you, I have burning sensation. But the reasons can be different. One will be having some nerve injury. One will be having some compression. So it can have different diagnoses. And there can be multiple symptoms, multiple mechanisms. And you cannot relate the intensity of pain equal to intensity of injury. You cannot say that a patient with a cancer will have more pain, a patient with diabetes have less pain. No, it is not at all related to the extent of injury. That's what we learned in the first session of pain, that pain is very subjective, and it's a very, very subjective. My pain is different, your pain is different. So we have to believe the patient when they say pain. So we'll go to the adjuvant analgesics, the major classification. You don't need to by heart the classification at all. There is something called multi-purpose adjuvant analgesics. We use that for many, many situations. The examples are tricyclic antidepressants. You don't need to remember any of this classification. Okay, I'm just putting it into order. That's also that it's easy to understand. You might have heard about amitriptyline, imipramine, and nortriptyline. All these drugs are TCAs, that is tricyclic antidepressants. These are very commonly used drugs for treatment of neuropathic pain. And as Madam mentioned some time back about steroids, sometimes we use dexamethasone or prednisolone for pain management. Clonidine is another drug which can be used for neuropathic pain. And sometimes we use local anesthetic. Any example of local anesthetic? Very commonly we use. Usually as injection, sometimes as medication. Lignocaine, bupivacaine, xylocaine. You've heard about this. Yes, 2% xylocaine. Yes. Sometimes we use topical NSAIDs, the diclofenac gel, you get the ibuprofen gel, etc. to apply topical. Third one is not, I have not used, it is not available in our country. It is capsaicin. Thank you, Sister Lawrence. Xylocaine, yes, local anesthetic is an example. Capsaicin is made, its basic essence is chili. We've never used it, but it is very, very effective in treating neuropathy. And you might have patients with bone pain. If there is a patient with bone pain, the commonly used drugs are bisphosphonates or corticosteroids or radiation. You don't need to remember by heart all this. That's why I'm just going through it. We'll come into detail one by one. What all you need to learn, I'll focus more on that. If there is a bowel obstruction, these are the adjuvant analgesics that we use. Corticosteroids, octreotide, and anticoagulants. So you will understand these are not analgesics, right? These are not painkillers. None of these is painkiller, right? Except NSAID probably, but none of these are painkillers. But we use these medication to control pain relief, to give pain relief. So we'll go to drug one by one. You don't need to remember so many things, but to understand the drug, amitriptyline is one of the very commonly used adjuvant analgesic. Generally, it is used, it is a antidepressant, right? This is given for patients with depression and they sleep. You take the medication and sleep off. But when you treat depression, the doses are pretty high. When you treat pain, the doses are pretty low. This is not an antidepressant dose. This is the analgesic dose. So amitriptyline is an antidepressant, tricyclic antidepressant. It's a prescription drug. You can't just go and get amitriptyline from medical shop because people use it for depression or for sleep. So the starting dose for pain management is 10 milligram or 25 milligram. It is generally used for burning type of pain. We will go up to 150 milligram, not more than that. Okay, maximum dose. Why? Because it is a very sedative drug. Many patients will not, very less patients go beyond 50 or 75. It's very, very sedative drug. Generally, we don't give it in elderly patients because it can cause sedation and urinary hesitancy. So it is not really recommended for very elderly patients. And so what you need to understand is the dose. What are the side effects? The patients, if they are drowsy, they get up in the morning for going to the toilet, they may actually have a fall if you give it for elderly. And you have to ask, if the patient is on amitriptyline, you have to ask whether they have good urine output, whether there is any issue with micturition, because there is a chance for urinary hesitancy. The urine will not pass. They have to stand for a long time to try having the urine out. So you have to ask all these questions. The last part, amitriptyline has anticholinergic side effects. What do you mean by anticholinergic side effects? Everything will be dried up. That's the easiest way to remember. The mouth will be dry. They'll feel very, like, lips will be dry. They can't swallow because of the severe dryness. What happens when everything is dry? your stools will be hard, right? So these are the anticholinergic side effects. Everything will get dried up. Your saliva, your tears, whatever secretion. So there can be chances of constipation, dry mouth. Dry mouth is very, very commonly seen along with amitriptyline. These are the things that you need to remember, not the classification. I'm not going into mechanism, but when you get this slide, if you are very interested to learn, you can read how this acts as an analgesic. Another drug is duloxetine. Duloxetine is again another antidepressant. The main action of duloxetine is antidepressant, but we use it for diabetic neuropathy. Generally, we start with, here it is written 40 in the textbook, we start with 20 milligram. We give it mostly at night. Very good drug for peripheral, the diabetic neuropathy. Again, the same thing. Patient may feel sleepy all the time, so we have to give it little early. All these drugs, amitriptyline or duloxetine, we tell them to take at 7 o'clock. So that morning they'll be little bright. If you take it at 10 o'clock and then go to sleep, you will be sleepy in the morning. So we tell them to take it little early, like 7 or 8 o'clock. Definitely before 8 o'clock at night. Anticonvulsants. Any example for anticonvulsants that you have seen? Yes, Eptoin is an anticonvulsant. Yes, Mehboob.
Phenytoin and Gardinal.
Yes, commonly used anticonvulsant. Yes, diazepam, correct. Anyone has used this for pain management? Any drugs? So there are some drugs. Yes, gabapentin, very commonly used anticonvulsant for pain. Even whatever drugs you mentioned, some of the drugs are very commonly used as. I think Sister Sylvester is trying to mention about pregabalin. I can see the pre, so I'm assuming it is pregabalin. Yes, pregabalin is an anticonvulsant. So these are the commonly seen anticonvulsants, pregabalin and gabapentin. Doctors use gabapentin a lot, but the problem is that, did you see the drug dosage? 300 to 3,600 milligram per day. In our country, we get 100 milligram dose. So to reach 3,600 milligram, you have to give 36 tablets. It is not possible. It has a wide therapeutic range. So titration will take time. So generally, gabapentin, although doctors prescribe gabapentin is the most commonly given drug, that is not the ideal choice. We have to start with amitriptyline, the basic drug. If there is no contraindication, it is a wonderful drug. Then if not tolerating, if the patient is elderly or has urinary hesitancy, then we can give pregabalin. This is another wonderful drug. 75 milligram to start with. I start generally everything at night because all these are sedating drugs. If you give it in the morning, the patient will be very drowsy. So give it at night so that they can get a good sleep also. So just to understand, you have seen a lot of gabapentin and pregabalin in your setting. Many of the doctors are in love with those drugs, but just look at the cost of the drug. Amitriptyline is the cheapest one. It costs only 17 rupees for 10 tablets. Gabapentin 10 tablets is 110. It is not a big price, but that is for 100 milligram. You have to start at least with 300 milligram. And if you want to increase the dose, how much the patient should pay for a week? A lot of money, a lot of difference, right? Even the pregabalin is again slightly expensive than amitriptyline. So we start with amitriptyline generally. If it is not tolerating, if there is a lot of side effects, then we switch on to pregabalin. Other drugs that we use is carbamazepine and sodium valproate. Sodium valproate is another anti-epileptic, which is very commonly used for managing pain. You start with 200 milligram and then you can go up to 1000 milligram. That is another commonly used drug. I have not seen much of a drowsiness or any other side effects with these two drugs. Even pregabalin is also not very drug, but some patients feel very drowsy with pregabalin also. That is one thing. When you give neuropathic pain medication, give it at early night so that they will wake up very fresh in the morning, and ask for side effects. Now you know the side effects. You have to ask for it. Another drug is, you don't need to know the dose because it is very rarely used. In our setting, we use that a lot, but it is not commonly used in any of the palliative care setting. That is, one is oral ketamine. It is generally used to treat the central sensitization. When the patient is telling head to toe pain, that means was not controlled in the beginning. It has taken over to the central nervous system. That is the time where we give ketamine, which is an anesthetic, which is a dissociative anesthetic. You can't just randomly use it. You have to have a good training to use this drug. Now you mentioned about the drugs like lignocaine and cylocaine, right? What is the disadvantage? We have to be very careful while using local anesthetic about one thing. Cardiac arrhythmias, right? If you don't use lignocaine right and left in any setting, right? You have to be very careful about arrhythmias. So again, you have to understand the dose and the limitations of all these drugs. And we use topical NSAIDs. And capsaicin is not available very commonly in our country. I have personally not used that. Another pain very difficult to control is bone pain, especially when there is metastasis to bone. It's very severe and it is very difficult to control with opioids. The preferred management is radiation. So if someone is having a bone metastasis, a lesion in the bone, generally they give radiation to that site and the pain will be reduced. If you cannot give radiation, they've already done that, still having pain, then we use bisphosphonates. Very commonly used drug is zoledronic acid. You might have seen this in your patients if you are seeing cancer patients. The moment they get diagnosed with multiple bone metastasis, they start the patients on bisphosphonates. And these are another group of drugs that we use to treat pain, adjuvant analgesics, that is muscle relaxants. When someone is having muscle spasm, we give drugs like baclofen, right? Or thiocolchicoside, any drugs which will release the muscle. Or someone mentioned about benzodiazepines. We don't use diazepam, but we use lorazepam and clonazepam for the muscle relaxation effect. Sometimes if the pain is due to infection, someone has severe infection which is causing severe pain, you cannot give paracetamol there, right? You have to give antibiotics and treat the infection. Sometimes we do give anticholinergic drugs, that is drugs which reduce the motility, reduce the secretions whenever there is colicky pain. You might have seen using Buscopan, right? When someone is the cyclopam, it's another muscle relaxant, or it has a little bit of anticholinergic activity also. So according to the pain, you can use some drugs which is not essentially pain medication, but you can use in a different dose for managing pain. So just to summarize, chronic neuropathic pain is not a symptom, it is a disease. It is something which we have to understand very clearly and to treat accordingly. If you treat the pain, those pain earlier, then the damage will be less. If you delay the treatment, there will be more and more damage to the nerve, so it becomes very difficult to treat later. And if the damage has already happened, then you can't give 100% pain management. So it is very important to treat any pain, especially neuropathic pain, much, much earlier. Sometimes polypharmacy is essential. As I said, you combine non-opioids with adjuvants. So I'm giving 2-3 drugs together with paracetamol. So my patient will have a prescription of ibuprofen, paracetamol, and amitriptyline. So it looks like a polypharmacy. But sometimes rational, I have to write why I am giving this combination. You should know why this person is taking this combination, what kind of pain this patient has. Sometimes we need to have polypharmacy. Along with this, it's very important to have the non-pharmacological like physiotherapy, acupuncture, all these treatments come into play. It is very, very essential when you treat chronic pain. So multimodal approach, even counseling. As I said, phantom limb pain. I give amitriptyline, but along with that, I have to give some therapies. so that the patient will get good pain relief. And expensive fancy drugs does not mean that they are more efficient. The basic drug like paracetamol or ibuprofen or the amitriptyline, these are the cheapest drugs, and that those are wonderful drugs. And sometimes we may not be able to give zero pain, so it is better to have a realistic goal for us. We can't imagine, you cannot aim at, you can aim at, you can try for it, but sometimes in neuropathic pain you may not reach to zero. So have a realistic goal and discuss it with patient. I'm just, I don't think we have the time for the case discussion. I'll send it across. If anyone is interested, can go through the 2 cases also. We can spend a few 2-3 minutes for any questions. This is a lot of information, lot of drugs in one session, but that happens like that because it comes together. You can't separate this into 2 sessions. That's why everything comes together. I try to simplify as much as possible. Otherwise, we would have gone into a lot of pharmacology today, so I deleted that. So just, you can ask any questions if you have any doubts.
Honestly, I have not heard such a beautiful and simple session about pain for nurses. Never ever in my life. So thank you so much, ma'am.
I think it's very, very important as nurses. Sometimes we think that why should I learn about all these medications? Anyway, it's the doctor who prescribes all this, right? Why should you learn about it? It's not. But when it comes to palliative care, I understand the nurses play a major role. I may not know about the dry mouths, right? So you have to tell me, doctor, you cannot, I don't think you can increase amitriptyline because the patient is already having constipation or urinary hesitancy. That's how I learned that the importance of nurses when I prescribe. Yes, Sister Meherul. Ma'am, you are muted.
Yeah, all these antidepressant drugs, almost it has, like dryness of mouth. One of my relative who was hypertensive was started with Amitri, and she used to have, total dryness, and she used to go into breathlessness.
Yes.
So like breathlessness could also will be like, aggravated along with the all these medication. So we need to take care of like some lubricant applied onto the nose also. So like it will give him the easiness to breathe.
Yes, very, very, very important. Sometimes they say they have a choking feeling. They say that something is stuck in the throat or they can't because there is no, we don't understand the importance of saliva because we have a lot of it. When you become dry, then you can't swallow anything.
Yeah, and one more thing, while eating, they feel that dryness of swallowing. Yeah. So then they feel tightness in the chest, and as if their breathing is stopped totally, they feel it like that. And one more thing I would like to ask you all, ma'am, that like acupuncture, you said, instead of acupuncture, I do try acupressure. Only there are a few points on your hands, you can wear, your hand is a replica of whole body.
Ma'am, I think we lost you. I totally agree to her. In any therapies, when I said puncture, I'm not an expert in that. I don't know the details or the difference between all this. But any approach, any non-pharmacological approach which gives relief. For example, a simple massage. If you just massage the patient, they feel better. Everywhere the gate control theory is going to play a major role. So any intervention, any non-pharmacological intervention is good for managing pain, especially chronic pain. I can see a question on anticholinergic. Sister Alvin, anticholinergic is covered in detail in the session on bowel obstruction. That's why I just didn't touch up on that. But the major action is to dry up and reduce the movement in effect. I think Nortriptan, I guess it is Nortriptyline. If it is Nortriptyline, for lumbar radiculopathy and disc prolapse. So in those cases, generally they give it for a long period of time, along with physiotherapy and other non-pharmacological methods, then gradually taper. Generally, I've seen it for longer period of time because the pain is chronic, right? Your disc prolapse is still there. The compression is still there, the radiculopathy is still there, but they encourage physiotherapy so that this is corrected to a little bit and then reduce and taper and reduce the drug. So generally it is given for months, probably 2 years also. Related to amitriptyline versus gabapentin pregabalin. Then amitriptyline, because amitriptyline will cause agitation and irritability in many patients. Definitely, Divakar, I think there is no simple solution when you choose a drug. So what we practice is we start with amitriptyline and see whether it is acceptable. Like you said, if I give amitriptyline, if it is causing agitation and irritability, I will not continue it. After all, we are working for the patient's comfort, right? Then I will not go for the cost. But what I'm telling is that without even trying the basic drugs, generally we see that people jump onto gabapentin and pregabalin, and they might not have tried amitriptyline. So definitely patient's safety is the primary thing, patient's comfort. Rather than safety, I will say comfort. If the patient is not comfortable, I will not give amitriptyline at all. So, but the effectiveness is more with amitriptyline is what studies have shown. The number needed to treat to get effective pain relief for amitriptyline is much ahead than pregabalin and gabapentin. So the evidence says that it is the most effective drug, but with side effects. I have not seen major side effects with amitriptyline, but you said sometimes urinary hesitancy, dry mouth, irritability can be seen. Then we stop. Let's give pregabalin. There is no argument in patient safety and cost effectiveness, not at all. Would like to discuss more about barrier that affects the use of analgesic guidelines. Sister Arati, the biggest barrier is none of us have learned it, right? In this group, most of you have not heard about the ladder. When I was an intern, I heard it, I hadn't heard about it for 4 years. And we run courses for doctors who are who are in this field for many years. None of them are have learned about analgesic guidelines. And in the medical education, it is very recently introduced. This analgesia or pain relief is introduced in last 3 years only. So I feel personally, the major barrier is lack of understanding. No one knows about this ladder. The second major barrier is the availability of drugs. I don't know how many of you have access to the drugs in all 3 steps. Step 1, you have access. Once you go to the next session, the step 2 and 3, you may not have this drug in your setting. So how will you use it? You may not have morphine. You may not cannot use morphine in a patient's house. You just have an injection fentanyl in your hospital. You can't use it, right? So the barrier is lack of understanding among professionals, including doctors and nurses. Second is unavailability of these medications. And even if in places you have the medication, you don't know about the ladder. You don't know how to use it. You don't know the dose. You don't know anything about it. That's the biggest barrier. I think, sorry, I exceeded time, but the questions were really interesting. So I just had to answer. Can we quickly, Anu, can we start the case presentation now?
I wish to request Mr. Divakar, who is a BSc Nursing, MPA, MH Nursing Officer from AIMS, Mangalagiri, Andhra Pradesh, to do the presentation.
Yes, ma'am. Thank you, ma'am. Good afternoon to all. Today I am going to present the case regarding intestinal obstruction. I have selected a patient whose age is 76 years, female. She was diagnosed as a endometrium with right ovary in 2018, and she underwent surgery for that. Status was hysterectomy with right salpingo-oophorectomy was done in 2019, and now she was diagnosed as intestinal obstruction and came to our hospital for treatment. While presenting to the hospital, she has the following complaints: frequent vomiting for the past 2 days, constipation, pain in the abdomen, swelling over the abdomen, and she is having increased temperature. History of illness: patient was diagnosed with cancer endometrium and right ovary on 2018. After that, she underwent hysterectomy plus right salpingo-oophorectomy on 2019. 6 cycles of radiotherapy was given, and patient was treated with chemotherapy drugs. Patient was perfectly all right till 3rd of January. She got sudden symptoms like vomiting, abdominal pain, fever, constipation on the evening of New Year. Patient reported to emergency department on 3rd January. All routine investigations were done. One USG whole abdomen was done. In that, inflammatory bowel with intestinal obstruction was noted. She was planned for emergency surgery and operated on 4th of January. On examination, her temperature was increased, was 102.6 degree Fahrenheit, and all other parameters was normal. Patient is febrile. On abdominal examination, abdominal was tenderness and she is having RNS. S1, S2 were normal. Uh, Treatment and significant investigation. Patient was operated on 4th January. Bowel resection with colostomy was done. On routine investigation, all parameters whichever somewhat increased, I have mentioned here. Her hemoglobin is 9.1 and TLC count is increased to 12.9. Normal TLC count will be 4 to 10. Here it is increased to 12.9. Then in LFT, serum bilirubin was increased and albumin is very low. In KFT, nitrogen, blood urea, serum creatinine, everything were increased. In sodium, potassium, everything was increased. New USG inflammatory bowel with intestinal obstruction was noted. And after the surgery, her resected bowel was sent for biopsy and report is awaited. Physiological aspect: patient is very much depressed about her biopsy report because she is suspecting that may be a new cancer. Patient is very much afraid of colostomy bag and its care. She is refusing to take any feed and asking her relative to take her back to home. She is thinking that her relatives were hiding something from her that may be a cancer and she will die soon. Both of her sons were in US and she want to meet them. These were the psychological aspect for my patients. Okay. Then medication. Patient was treated with the following medication: injection PCM 1 gram TDS, metronidazole 500 mg TDS, cefuroxime 1.5 gram TDS, injection tramadol 100 mg IVBD in 100 ml NS, injection emised 4 mg BD with the tramadol, injection Pandop IVBD, and IV fluid NS 3 pin, DNS 3 pin, NS 2 pin at 100 ml per hour. Main concern here, the main concern about for my patient is colostomy and stomach care, physiotherapy, medication, physiological support, and regular follow-up. Summary: 76 years female patient admitted in emergency department on 3rd Jan and she was diagnosed as intestinal obstruction and was operated on 4th Jan on emergency basis. She is a known case of CA endometrium with right ovary and she underwent surgery for the same and she completed her chemotherapy and radiotherapy. Now she underwent bowel resection and colostomy for recently diagnosed intestinal obstruction. She was planned to discharge with colostomy bag. Now she is very much depressed about her stoma and its care and doubting that her relatives were hiding something from her. Regular stoma care, hospital follow-up, medication at correct time, physiotherapy were included in discharge plan. Teleconsultation number was given to contact at any time. Discussion point. Here I want to ask some question to the attenders. Here, why she is so much depressed even after the surgery? Because surgery is already done and she is perfectly all right, even though she is worrying. For what reason she is worrying?
Participants can use their chat box if they cannot unmute. Yes, Miss Mehboob, you can speak. Hello, Miss Mehboob. Do you want to speak? You are unmuted.
Feeling that just because she was operated first for oophorectomy and hysterectomy and all, then now second chance she is admitted for the colostomy. Then she is scared about near future that it might involve other parts of her body. Yeah.
Yes, ma'am. That's the correct answer. Because
Yeah.
she's thinking that she was again she got some cancer and relatives were hiding that one from her. That is her main concern, and for that
Yeah.
she is worrying.
Yeah.
Okay. And second question, she is having good financial support, and how we can give best stroma care to that patient.
I think there are a few comments in the chat also. I think Mamta is telling we can teach her. I think that's her response to it. To hire a home nurse if possible, if they have good financial support. Any other thoughts?
You wish to give only stomach care or any other support?
Ma'am, only for stoma care, ma'am. Yes, ma'am. Ma'am, recently we have a course like for treating stoma patients. Now specialist course were there, ma'am. Like after pharmacy, even BSc nursing, they are studying that course and they are giving specialist care to the stoma bag. If we are just dialing a number, means they will go to their home and they will change the bag, and once in a 7 days they will go and they will change the bag, and if they want, means they will teach them like how to change like that. But here she is financially supportive. She asked us like we can't change it in our home, we need a specialist person, like that they told us. So we given the number and that person will go and meet her 7 days once and he will change the bag.
Suppose
Then
there is an emergency at night.
ma'am,
Just for my
yes,
understanding.
ma'am, he will go at any time, ma'am, but if he is not attending, means that time she can report to hospital at any time.
Okay.
Okay. Third point to discuss, how we can psychologically support her.
I encourage everybody to use the chat box if there is a problem in unmuting yourself.
Okay, ma'am. Her main concern is like both of her sons were in US and no close relatives were there with her to care. So we can tell them to contact with in mobile to her, and daily we can allow her to speak with her sons 30 minutes, 40 minutes, ma'am. And we can support her like and second time she is not diagnosed with the cancer, that we have to explain her clearly. Okay, ma'am. Uh, Third question, why fourth one, why teleconsultation number was given to her? Yes, Aarti have answered to report in case of emergency. Also,
For
patient is
minimizing the hospital commutation.
yes,
Community
that's yes, that's also correct. And here one more point to be noted: patient is telling that I will die soon, like that she is having like some psychologically she is disturbed, so she can call to the telemedicine number, and if she wants means she can talk with the counselors. They will counsel her, and her mindset can change. And if there is an emergency and there is any stomach bag leakage, she can contact to that person. If he is not lifting the call means anytime she can call to telemedicine number and she can come to hospital. That's all, ma'am. That's the presentation. Thank you, ma'am.
Any of the participants have any doubts to ask? Sonia, then shall we wind up? Is there anything else?
I'll just add a few points. I think we'll cover most of this in the coming sessions, especially how to manage stoma at home, or how to teach them, what all things that you can train them. And I think most of these questions should be covered in communication, right? There is a reason why she is anxious. When you see, even when you have some investigation report to come, we will not sleep, right? If you think that there is something wrong, till the report comes, we'll keep checking the reports online, whether it has come or not, right? So she has undergone a major surgery, and she doesn't know what is happening, what is the report going to be. And this, when your children are not near, the anxiety will increase 10 times or 20 times when you are alone, and when your children are not around. That is one thing. And it is not at all a pleasant feeling to have your fecal matter right on your tummy. People will not want that to happen. That's a big psychological trauma to many, many patients who undergo colostomy. So, how to talk to her, how to um, uh, communicate about the illness and what is happening, how to listen to her, how to address these issues will be covered in detail in the communication session. But I think that is the answer which I would recommend in most of these questions. So all these questions or issues have something to do with the communication. To talk to her, to understand more about, okay, am I going to die? Why she is asking like that? We don't know. Has she overheard someone telling something? Or has she read about something? Or is she feeling very terrible inside her body that she thinks that she's going to die? So all these things need proper exploration. So this, if there is any treatment prescription for this particular situation, it would be definitely communication, and later on coming to the management plan. So that will be covered after 1 or 2 sessions of pain. We have 2 sessions specifically on communication and how to communicate this news to the patient. So that will be covered in detail. And thank you, Divakar, for bringing in such a detailed presentation, and you have gone in detail about the psychological aspect, which we encourage everyone to do rather than just focusing on the medications and the treatment. This is what we are looking for to hear from you. I saw that you're from AIMS Mangalagiri. We recently had a doctor from there attending our 6 weeks residential program. He's from community medicine. I don't know whether you are working together, but yeah, when I saw the institution name, I just wanted to convey that. And thank you so much. It was a very good discussion points also that you brought in, so that everyone can understand how the total assessment has to be done, how to go more deeper than just a case of CA intervention with bowel obstruction. Now we know what kind of a person she is, what is the support system, and what can be done for her. That's a wonderful presentation to discuss. Thank you. Thank you everyone for who has interacted in the chat. Anu, over to you.
If you have any doubt, you can contact the email address provided there. And let us
Thank
meet
you
in
very
next
much,
session.
madam.
Meet on Saturday.
Thank you. Bye-bye.
Thank you all for joining us. Have shared the feedback link in your WhatsApp group and in your chat box. Kindly fill it up. We'll see you on the next session with management of pain part 2 opioids. Bye bye.